Now's review of rheumatoid arthritis at EULAR 2024. I've convened a panel of friends and discussants, all of whom were involved in covering rheumatoid arthritis at the meeting, to hear their take on some of their favorite abstracts that concern rheumatoid arthritis and the drugs that we use in rheumatoid arthritis. So we're going to go a few rounds, have an interesting discussion. I hope you've enjoyed these panel discussions. I certainly have. I'm Jack Cush from Dallas, Texas. I want my friends to introduce themselves. Let's begin with Orly.
Hi everyone, I am Aurélie Najm from Glasgow. Nice being here with you tonight.
And David.
David Liu, Melbourne, Australia.
And Dr. John.
Jonathan Kay, Worcester, Massachusetts, United States.
We are covering the globe as we cover rheumatoid arthritis. This is what RheumNow does, I guess. So again, the rules are there's no betting, there's no cursing, there can be drinking, it's after hours. There you go. John's got a glass that looks like it's full of vodka or water.
Water.
Yeah, we know it's not one of your vices. Okay, let's begin with David Lewis. Well, actually, no, let's begin with Orly first.
All right, yeah. So I wanted to talk to you guys about the Amplified study. I don't know if you've heard about the Amplified study. The Amplified study was following a smaller study, which was the AMPLE study. It's a study in rheumatoid arthritis, and it's looking at patients that are inadequate responders to methotrexate. But most importantly, it's those people that we do believe might respond better to some drugs, especially those carriers of the shared epitope and those people with dual seropositivity. And so in that AMPLE study, which was not the one presented, but the one that kind of gave birth to Amplified, it seemed that people with carriers of shared epitope and dual seropositivity would respond better to abatacept in a small head-to-head trial against adalimumab. And that gave birth to this phase 3 randomized control trial with over 300 patients, all positive for both ACPAs and rheumatoid factors, and 65% of them carriers of the shared epitope. And the idea was abatacept is going to do better.
So before you get into the meat of it, I want to do a little prelude. And
yeah.
That there have been, I don't know, 5, 6, 7 studies that make the claim that if you're seropositive, you're going to respond better to abatacept than to comparator biologics, including TNFs. And I would say there are a number of studies, majority of studies, but they're not a double-blind randomized controlled trial like Amplified and AMPLE were. And these are either observational cohorts, retrospective analyses, and a few open labels. And then there are some data that actually argue this point. So the question of why Amplified was done is to really nail home this issue that maybe you do get an advantage to use abatacept in patients who are strongly seropositive. Go ahead, Dr. Nett.
Yeah, no, absolutely. And from a physiopathological point of view, it does make sense, doesn't it? Yeah, so over 300 patients, all dual seropositive, 65% carriers of the shared epitope. And they looked at week 24, who were the best responders using ACR 50. And big disappointment, actually, because what we saw is that the response was actually very similar in both groups, was roughly 60%. They did then look at the DAS response, and again, there was absolutely no difference. And so what it's telling us is that at least in these patients that are bio-naive, because, it might be that if you go to a population that has failed a few biologics, then you might have a different, outcome. But what it does seem like is that in this trial, at least there was no difference between abatacept and adalimumab, and they did stratify by levels of ACPAs, and they looked at that specific group that have very high levels that ACPAs have baseline, and they did seem to respond better, at least numerically. But I think because the numbers were a bit small at that point, they show a trend. But how high is high ACPAs? is the question as well.
Well, I think the entry into this was maybe 3 times the upper limit of normal, which is not gigantically high, obviously. So I want to ask the others, has this study changing your mind at all about the abatacept seropositivity story, David?
Yeah, so I mean, I remember, seeing the high level numbers for this before the meeting and thinking, geez, well, that's really disappointing, isn't it? Because I think we were hoping that maybe this might be one of the few biomarkers that we had accessible in terms of picking uh, um, preferred biologic or targeted synthetic agent off the basis of the tests that we conventionally do right now. And that's it simply was a swing and a miss. And I'm sure that orally we'll talk about synovial biopsies coming up, and I think something like R4RA has given us a little bit of hope that we might be able to do something else, but we're still chasing this elusive idea that maybe we can try and figure out which of the many different agents that we have might work better than another. And I feel like it's, here we are 15, 20 years later after having had 8 different biologic agents in rheumatoid arthritis, and we're still here. So I believe these data. I think, you can stratify out, the plausibility is there. And I did a video on this earlier in the week. You can pin as much as hope as you want on the plausibility, but ultimately the data have to speak for themselves. I think the other thing that we can talk about related to this is the data from Erlangen with the rituximab plus abatacept versus just rituximab being a bust as well. And I think that, speaks to the difficulties that we have.
Yeah, that's a sequential trial. Actually, it's a combination trial showing, again, as you said, no real benefit to that combination. John, what do you think of this data?
Well, I believe the data, but it's essentially a recapitulation of the AMPLE trial. In terms of the seropositivity, yes, it would be nice if there were a marker, but ACPA is a heterogeneous group of autoantibodies. There are fine specificities, and this study did not look at the fine specificities. It certainly would be underpowered to identify a single ACPA anti-citrullinated protein specificity that might be predictive, but it might be that a subset of anti-citrullinated protein antibodies might be predictive. So I wouldn't hang up the towel yet on this approach, but it would be low yield to keep chasing after a dead horse. I think that what we've seen is that clinically, abatacept and adalimumab are similar in terms of their efficacy. In terms of AMPLE, every single outcome measure was superimposable at all time points over 2 years, and we're seeing that here. This study, the shared epitope population was a subset of the patient population, and probably the study was underpowered to be able to detect superiority of shared epitope, and certainly double dose shared epitope compared to shared epitope negative.
Well, it was actually powered for the shared epitope population, but not for the double positive one, just for the, 1 or 2 alleles.
Right.
Okay. Interesting. And again, disappointing in that it's a negative result. Dr. Liu, what do you have?
So I want to talk a little bit about, if I was going to really nominate my own highlights, I just want to make mention of the debate I had with Janet Pope. It's not every day you get to debate someone like Janet Pope at EULAR, and we debated JAK inhibitor safety, which was a lot of fun. And I just want to reassure all of our listeners that Janet and I are still friends. We had dinner on Friday night. We hugged it out. So despite the fact that yes, I won. Like that we hugged it out and it was all okay. But I want to talk a bit about depression and rheumatoid arthritis.
Well, wait. If you're going to say that you won, what view did you back that gave you a winning vote by the audience compared to Janet's? What side did you take?
Well, I was saying that the warning wasn't the data did not support the warning. And to be clear, so we had a vote at the beginning, and the crowd thought it was 50-50, right on the dot. and we swung it out to 60-something%. And if we've learned anything in recent years from politics in recent years, is that a couple of percent swing can mean all the difference. So, I'm going to claim a victory here. I'm very much going to claim a victory.
Again, the debate was to look at the regulatory recommendations from all the countries stemming from the oral surveillance, and were they appropriate, and should we pay attention to them? And that was Janet's point of view. And Dr. Liu got to argue that, it's much ado about nothing. I mean, there's a message there, but maybe it's overblown, and the audience did sway a little bit that way. But nonetheless, I will say that in the voting that we did do, the audience did indicate that this is still a concern. And we know that this issue, going on 2-3 years now out, it's still a concern that we still need to, I think, have frequent discussions on. But go ahead, David, you were going to say another report.
Yes, well, there was a Polish cohort which looked at depression in rheumatoid arthritis patients, and I think it probably speaks to the issues that we've got. So under 2% had a formal diagnosis, but over 20% had low mood on HAC. But then you'd see as well that low mood is associated with, and maybe this isn't news, but low mood is associated with higher DAS28, increased swollen joints, increased tender joints, of course, higher patient VAS scores. What are we doing in practice to really try and identify low mood and depression in our patients, and actually really try and you see that as something we can lever off in a world where we've kind of had diminishing returns, I think, potentially on the incremental incremental improvements we've had for our rheumatoid arthritis patients? That, I think, is a question.
Yeah, I mean, I like these abstracts because they are reminders of this major problem. Was it ACR, last ACR, that the abstract, I think, from a Dutch group showed that there was an incredibly high mortality in RA patients who had depression. And I think the point is that we don't do this. So if Ted Pincus and Fred Wolf beat you up in the 80s and 90s to do a health assessment questionnaire on every patient, every visit, these data, which seem to come up every other month, should be enough that you should be doing a short form screen for depression in all your patients at every visit. I know I started doing it. I think it's important.
In the presentation about the Canadian cohort that looked at predictors of difficult to treat rheumatoid arthritis, depression was one of the predictive features.
Sure. Yep. And it's one of the key elements in other studies to this non-inflammatory refractory RA population, NERA, as opposed to the other difficult to treat RA population, which we call PIRA, which is a progressive inflammatory, persistent inflammatory, meaning that they either, if they're not responding, they either have inflammation or they don't. And the ones that don't have depression, fatigue, widespread pain, a number of other factors that are in play. So yeah, I think we need to pay more attention to this. So I think it's good that you bring this out as an important abstract from the meeting.
And if I can just highlight a presentation that I gave last year at Milan, presentation looking at women with postpartum depression. Women with inflammatory arthritis had a significantly increased risk of postpartum depression compared to matched controls, women without inflammatory arthritis. So it's very important for us to address depression and to identify patients with depression and start treatment.
Agreed. Okay. All right. Dr. K, what's one of your favorites?
So well, I have lots of favorites, but Kevin Winthrop wins again. Kevin is our infectious disease specialist to the rheumatologists, and he looked at vaccination with recombinant herpes zoster vaccine in patients with rheumatoid arthritis treated with upadacitinib and methotrexate, and found that without stopping the upadacitinib, both humoral immunity and cell-mediated immunity were fine. He then looked at a population of patients, 35 individuals in a study who were of patients being treated with abatacept, and about 11 of these 35 patients were on concomitant methotrexate. The remaining 24 were not. and they had no cell-mediated immunity when they continued the abatacept at the time of vaccination. So contrary to the recommendations for COVID vaccination, where we're told to stop the methotrexate for 1 to 2 weeks after the vaccine to optimize immune response to vaccination, and to hold the JAK inhibitor for 7 days after vaccination, continuing methotrexate and upadacitinib after the vaccine dose seemed to have no deleterious effect. So it points out, first of all, we know that herpes zoster is increased in individuals taking JAK inhibitors, so it's very important to have them immunized. And even if you started the JAK inhibitor, you can go ahead and give them the 2 doses of recombinant zoster vaccine without having to stop the JAK inhibitor or their methotrexate and still achieve adequate immune response. However, on abatacept, which is a drug that we've been talking about a lot, abatacept, because of its interference with T cell co-stimulation, inhibits the cell-mediated immunity to the zoster vaccine, and also reduces, but does not completely ablate, the humoral immune response.
You know, I was on a panel with Kevin and a bunch of other rheumatologists to develop some teaching slides on vaccination practices. This would have been going back about 8 or 9 years ago, really before the JAKs appeared. And the overwhelming takeaway from that panel was methotrexate's the bad player. That methotrexate really impairs cellular and humoral responses almost in every study. And the other bad players would be rituximab, and then very, very high dose steroids. But all the other drugs, including abatacept, IL-6 inhibitors, and all the TNF inhibitors look great as far as, vaccine response. And they're mainly looking at pneumococcus and influenza were the main studies that we looked at. So I've always been of the opinion that methotrexate is a big culprit here. And the big surprise with Kevin's research is that not that they did well on UPA, but that they did well on UPA and methotrexate. And that I find surprising. But, that's, there may be an element here of the methotrexate plus the reason you're given methotrexate, meaning it's they're not well controlled, and maybe if they're on a JAK inhibitor and a methotrexate, they get better, faster control, and inflammation control of inflammation allows for better vaccine responses. So there may be Kevin did a report from last EULAR, I want to say, that was on TOFA, and no, it wasn't him. Yeah, there was another. He had another report, but there was another report from I want to say Norway, where they looked at patients on JAK inhibitors and showing that around 30–40% who were on JAK inhibitors and got a zoster vaccine did not have a good response. So this is still a dicey area. I find that this is encouraging, but I'm still going to hold for a week when I'm on methotrexate, regardless of what vaccine I'm doing, mainly because of the PARC data that was a ACR presentation from plenary, and then his repeat data that showed you don't need to wait 2 weeks. You're going to just do 1 week. John, do you think that this data from Kevin's going to change your practices?
It makes me a little bit less uncomfortable if the patient continues their JAK inhibitor. If they're on abatacept, I will definitely instruct them to withhold it, probably for 2 weeks after the vaccine, and to try to time the vaccine if they're getting it monthly, halfway in between the 2 doses. I feel a little bit less uncomfortable with vaccination in individuals taking a JAK inhibitor. I wouldn't say I feel more comfortable, but I definitely feel uncomfortable with the potential response if a patient's on abatacept and continues the abatacept around the time of vaccination.
Yeah, I'm sorry to talk too much on this, but I get really excited on this subject. I know David is also chomping at the bit here, but the other important thing is that these people got vaccinated on a JAK inhibitor. Right? They were already on the UPA and they got vaccinated. Isn't that right?
Yep,
Which
absolutely.
that makes people very concerned. Do I have to stop the JAK and then give the vaccine? So I think that's an encouraging aspect of the study as well. David,
And also,
go ahead, John.
and I would just make the comment that because the JAK inhibitors in individuals who respond are so effective, and stopping them leads to flare of disease relatively quickly, it's not great for the patient taking the JAK inhibitor to have to stop it for vaccination.
Exactly. Other comments?
Oh, I mean, I think I would really love us to see data with JAK inhibitors plus withholding methotrexate. I know in select, when you're doing a sub study in select compare, you can't just go about randomly withholding methotrexate for things like vaccination sub studies. It would be clearly very useful data that would inform our practice, with the idea that plausibly, we've seen a lot of correlates between influenza vaccination and the patterns that we see there in COVID vaccination and possibly zoster vaccination as well. But I mean, surely, as much as maybe we were a little bit surprised by the Bataset results, that the complete lack of cellular response from a Bataset, I mean, that is really disappointing. We've got to try and find better ways, and you got to wonder whether withholding a Bataset for a week or two might not help to improve the immunogenicity. I wonder what people think about that.
Mm-hmm. Well, I'd like to see the study rather than guess. So,
yeah.
Orly, is this going to change your practices at all?
Yeah, well, to my opinion, it doesn't say anything about the methotrexate. I would not take any conclusions from that for the methotrexate one, but definitely it just reassures me that anybody that I've already started on JAK that didn't get the, I'm much more confident to give them the vaccine without withholding. But I was just having a look because there was another abstract looking at the pneumococcus vaccine as well, and there were I was just trying to look into that. They were looking at also withholding methotrexate, no methotrexate, and the responses were also quite good. So, I think it's one of those one. And also with methotrexate, it doesn't say, is there a dose? Is there a cutoff dose that, over it, maybe it impairs the response, maybe under not? Is there a difference between subcut, oral? That's some of the stuff that I would really like to know more about.
Yeah, the caveats here are many, and the nuances in the design of the trials and how many arms you have, and that's why you probably don't see the data that you want, because these are difficult trials to do, and you need a cohort of like 10 to 15 at least in each group to get something meaningful. So, all right, let me go ahead, Orly.
Yeah, I'm gonna say I found the pneumococcus one actually. So it was Vaximra. That's how it's called. And they had 270 patients, and they did vaccine at the time of methotrexate or vaccine and then start methotrexate 1 month later. And the humoral response, they didn't measure cellular response, was 76 versus 88%. So it was good, but it was obviously better if you do vaccine and then you start methotrexate.
Right. Which
I mean, you'd have to be brave to tell your new RA patient that I'm going to wait 4 weeks. I know that in the data showed that the steroid utilization was the same, the disease was the same after a year. But geez, I'm not telling my new RA patient, let's just wait 4 weeks on the methotrexate. Don't worry, guys.
Well,
but get your pneumococcal vaccine. Yeah.
David brings up a good point. Whenever I brought this up in clinic, we're going to give you the influenza vaccine. Hold your methotrexate for 2 weeks was the message a few years ago. And the concerned look on the patient's face was like, what? Why? And so it got a little better when we said only hold it skip 1 dose, and a little less protest. But the patients who are doing well on methotrexate sometimes are not too happy about this. Takes a little coaching. So, all right, let me give you the what I think is a novel little study. It comes from Andres Kirschbaumer from Austria, where he studied the effects of geography on placebo response rates in clinical trials. What he did was review rheumatoid arthritis, double-blind, placebo-controlled clinical trials using an ACR20 response rate, and they had to be placebo-controlled trials, going back to 1994 and all the way through to 2019. So they had a lot of trials. And what they did in the poster was they showed you a map of the world. And in one half of the study, they showed you where all these trials were done. And in 1994, they were pretty much all done in North America. Mostly US, a lot in Canada. And then as you go from 94, 95, 96 and go on all the way to 2019, you can see the spread of the clinical trials being done, color-coded, to Western Europe, and then throughout all of the rest of the world, including USSR, Southeast Asia, Australia, and then ultimately even in South America. So it's a much more global, and this is, those of us who do clinical trials know this to be so. It's gotten harder and harder to enroll patients from the United States, and that's why companies have had to go global. But then the interesting part of the study is they showed the placebo response rate in all these trials against, and that's on the y-axis, against the normalized gross national product of each country. And they had a slope like this, such that the countries that had the poorest countries had the highest response rates, as high as 40%, and that the richer countries had the lowest response rate, around 20%. And when we started doing clinical trials back in the 90s, we would see 15, 20, 21% response rates, but now we see, much higher response rate, 35%, 30, and we're wondering, well, that's because they're bringing in all those other countries and the rest of the world that are ruining it. And it turns out that that is partially true. The question is, how is GMP influencing the placebo response rate? And my simple explanation is, it's a surrogate measure for how many treatment options you really have. So in a rich country, you've got a lot of treatment options. So, and if you don't have treatment options, you're less likely to say, ouch, when they're squeezing on MCP2, because you need to be on something, because if it's, I don't have the money to afford the drugs in my poor country, and whatnot. So I think it's a nice little explanation of what we've observed over time.
Absolutely. Back about 20 years ago, I looked at a MAP kinase clinical trial that was done in Western Europe and in North America for half of the patients, and the other half were in South America. And there was a dose response in the Western Europe, North America group. There was no dose response and an incredibly high placebo response rate of almost 60% in South America. Now, that might be that the patients there were not compliant with their methotrexate before the study. And once they entered a clinical study, they were followed more closely and were more compliant with their background medication. Or it might just be the nature of the patients and their response to any kind of treatment.
Exactly. Yeah, this is an interesting phenomenon. All right, let's go around the horn again. Dr. Name?
Yeah, so I'm gonna talk about a topic that is close to my heart. I do a lot of research on synovial tissue, and so obviously I couldn't not talk about this oral presentation from the Rome group that presented their study of synovial biopsy. And so what they did, that they biopsied over 300 patients that were naive, rheumatoid arthritis naive, and they were interested in looking at different levels. Because we know when we did the F4RA study back then, the London group presented and showed that maybe some patients with a specific pathotype, so with a specific type of cell infiltrating their tissue, they were maybe more likely to respond to this or that drug. It was not fully convincing, and so what they were interested to do in this study was to look, first of all, whether there were differences in the tissue if you're going to respond to your first treatment to methotrexate, you want to get in remission or not. And so what they did is they did very basic staining and histology analysis, and they did the score called the Krenz score, which looks at the amount of inflammation that's in the tissue. And so what they found makes sense, the less inflammation you've got in the tissue, the more likely you are to respond at 6 months to your first treatment. Okay, well, until then, that's fine. They looked into the pathotypes. So, is there more myeloid cells in there? Is there more lymphoid cells in there? Or is there more of nothing, which is what we call the post-immune pathotype? There's just not many cells infiltrating. And as opposed to what was shown before, that, the thinking was, oh, if there's not immune infiltrate in the tissue, if you give immunosuppressive drugs, it doesn't work. Well, actually, they found the complete opposite. if there's not much inflammation and not much cell infiltrating the tissue, people are more likely to respond. In fact, the response to conventional DMARD is 60%, as opposed to those with a lot of myeloid cells, which was 36%. So, we kind of almost doubled there. But they didn't stop there. They then disaggregated the tissue and they did some flow cytometry, and they looked into specific cells population that we know are associated with high chances of reaching remission. And so what they found, if you've got a specific subset of macrophages in your synovial tissue, and you got above 40% of these cells, your odd ratio to be in remission at 6 months is 24. I mean, what biomarker do we have that gives us a prediction with an odd ratio of 24 to reach remission? I've never heard of that before. So, I think it's really interesting and I think it's promising. Obviously, it's not ready for clinics just now. But if we were able to, identify some of these biomarker and translate that into blood's biomarker, for example, how powerful could that be? So I think this is something that I found massively exciting personally.
How early were these patients in their disease course? Were these, 10-year established disease, or were these people in the first 4 years?
Naive of any drug. So, I mean, obviously it doesn't mean that the symptoms started yesterday, but I haven't seen what was the duration of symptoms beforehand, but you can imagine they were pretty early in the course of their disease.
This is different than Pitsalis' study, where they showed that there was a lot of non-response basically, and all that was related to fibroblast and stromal cells. Yeah. And it turns out that the histology wasn't nearly as good as the differentially expressed genes, and that was maybe a little bit more predictive. But this, I think, is because I think they get them early enough that the synovial biopsy might be more predictive and tell you who's going to respond. And as you say, an odds ratio of 24 is a powerful number that should be pursued. But I don't know in long-standing disease, established disease, that the biopsy is going to be quite as helpful unless you're dealing with flare situations or whatever. But this has always been like the holy grail of researchers. I played in this for a while as well. And I had to move on to something else because I wasn't getting any fame out of that. But don't bang your head against this wall too hard is what I'm going to suggest if this is still what you're going to do.
Yeah, but to my opinion, we know now that the drugs that we give do impact the tissue. And so obviously, if we look at established disease that have already had 2 biologics, we look at something very different. But also, most importantly, I believe that the tissue is fantastic to understand the biology. But I don't know that we're going to use that as a biomarker per se. I think it's great to give us cues to then maybe move into something more achievable and accessible.
The holy grail is knowing a pathotype that predicts, or that relates to a phenotype, but the pathotype tells you where you need to go in targeted therapy. Because right now we're flipping coins and guessing about what we're going to do. John, what do you think of this data?
I think the data are really interesting. I think that the important thing is to come up with clinically relevant biomarkers. In clinical practice, the average rheumatologist is not going to perform a synovial biopsy and won't be close to a center that can disaggregate the tissue and do flow cytometry and single cell seq or whatever is necessary to come up with this information. But possibly looking at these markers and then trying to understand using deep learning what clinical features might correlate, and we might actually come up not with a hazard ratio of 24, but maybe something like 8, which would be darn good. So I think it's very promising that this is segregating patients into potential responders versus non-responders, and then we should take this and go bring it closer to the clinic with, as you said, more accessible biomarkers.
All right. David, what's your second one for today?
I'll just make, I know we're running short on time. I'll make a quick one. As a clinical pharmacologist in my other life, I just want to make mention of the therapeutic drug monitoring debate. So therapeutic drug monitoring, that process of using drug concentrations to help guide prescribing. It's a really fascinating EULAR debate. I think all the EULAR debates were great this year. So Desiree van der Heijden, who is not a TDM person, was thrown in on the negative side of things. I think she made some really strong points, which I think probably go at the heart of some of the, I think, reasons why TDM hasn't had the same traction in rheumatology compared to, say, gastroenterology, to IBD, where we've seen it really become mainstream. And she asked questions about, but why, especially when adverse events from TNF inhibitors are low, that we've got many drug choices in rheumatoid arthritis, that we've got low drug prices of biosimilars, and overall we have little to gain from trying to optimize drug dosing, especially when it comes to escalating. So Gertjan Volpnik, who's I think the godfather of rheumatology TDM, did say one way to get rid of TDM is to get more drugs, and that's what we're doing. And it's true that we've had all these new drugs for rheumatoid arthritis that mean that the proportion of we've had to work less and less hard for our outcomes in terms of choosing a therapy. Some of the outcomes outside of that are things that we need to be working on, but we just cycle through therapies instead of trying to optimize doses, and that makes it a lot I can think less appealing to do TDM. But potentially the benefits in my mind, and this is my kind of editorialization of this, is I think there'll be other settings. Maybe, if we are insistent on trying to reduce doses in some people of biologic agents, then one of the ways to do that might be TDM, because you're coming down the sharp side of the concentration effect curve. You're kind of getting to the bits where actually concentration might make a difference. Things like that are going to make a lot of sense in terms of TDM. But right now, it's probably been hard for us to pitch a reason why, given that high concentrations haven't seemed to consistently lead to better outcomes, haven't seemed to consistently lead to toxicity, and we're really struggling to be able to make an argument as to why you should do drug concentrations for your TNF inhibitor treated rheumatoid arthritis patients.
So I assume Desiree won the debate.
Yes, but by small percentages again, but small percentages win. Not just to mention that to Janet once again.
Well, certainly wins elections, so we'll take it in debates as well. All right, that's cool. John, what's your last one?
So my last one is two posters from Thomas Hugel's department in Lausanne, Switzerland. Posters 0451 and 0607. 0451 looked at finger pad or finger fold distance, and we have these folds over our fingers that go horizontally, and the width of the finger and the distance between the folds the distance increases with joint swelling. So for remote patient monitoring, it would be helpful to be able to take photographs using an iPhone or another digital device, and then to analyze these. And so Thomas Hugel, who's very involved with artificial intelligence in rheumatoid arthritis and other rheumatologic diseases, has developed this app where they can take the photograph of the PIP joints of the second, third, and fourth digits, and then measure the distance between the finger folds and the ratio of the distance to the width of the finger fold, and come up with numbers. It's not yet reliably predictive of joint swelling, but certainly is a start and promising as one of the potentials for remote patient monitoring. The other poster looked at their Mephisto program, which is an app where you take a brief video of a patient making a fist 5 times as rapidly as they can, and then that uses geographic localization of the fingers and measures flexion angles and rate of movement. And as patients have more inflammation, their ability to make a fist slows down and their angles are limited. And if their disease gets better, they can do it much faster, and their excursion is a larger distance. So I thought that these were both rather clever and potentially applicable to remote patient monitoring. And as we go more to telemedicine and having the ability to directly examine the patient's joints, with your fingers using these technologies may be useful in assessing disease activity.
It's very cool to watch these in play. It's you know, it's almost like, you know, technology becomes the shiny rock that we're drawn to. The question is, will we actually use it, and can you integrate the data? What was good about the Mephisto was that they actually did like a cohort from 3 centers, 80 patients, and they did clinical assessments, and then they did the, you know, the range of motion like this, and they showed good correlations, reasonable correlations with hack scores and also with -28 measures as well. So suggesting it could be, you know, a useful tool in outpatient assessment. So the one thing I've heard during, especially during COVID, and as a big believer in telemedicine, is that most people didn't know how to assess patients by video or over the phone, and I've got 2 videos on how to do the virtual joint exam that I think are highly instructive. Yeah, it's not for everybody and every patient, but to say you can't do it and then not do it, you're missing out on an opportunity. Here are tools that will make you better. So this is kind of cool. It's got a wow factor to it. That's all you can say. It was and he showed you basically use a cell phone and to take the pictures for the finger folds and the cell phone to do this kinetic assessment of joint movement and flexion specifically. And again, it measures PIP and DIP, not MCP activity, all that well, but still.
Yeah, I remember I was sharing a session where he was presenting that last year at EULAR, and I was quite interested, you know, to know how discriminative it can be for osteoarthritis, because these people also have kind of swollen, in just a different type of swollen. So that's something because osteoarthritis is much more common than RA. So that's something I'd be quite keen to kind of know.
But I
That's
think
an important point, and I don't see these tools as being used in isolation. I see them as being part of a panel of digital tools, and with validation in patients with osteoarthritis and those with rheumatoid arthritis and those with both, a couple of different assessments will perhaps be able to ferret out what is osteoarthritis and what's rheumatoid arthritis.
and the
Can I
patient
just shout
has
out?
no control.
Sorry.
Go ahead, David.
I just want to say I've just written an article on the RheumNow website about caution about how we approach new technologies and how we try and consider them and the caution that we need to have, the rightful caution I think we need to have. And this is as someone who is a believer in, and I think sees enormous potential in computer vision and trusts Thomas Hugel to be able to try and figure out the right path. But go check that out on the RheumNow website.
Okay. My last one's going to be a real quickie about palindromic rheumatism. It's a study from Leeds, 161 patients who were largely DMARD naive, followed for 3 years. And as you know, palindromic comes and goes. And what they did show is that over time, with a mean of 3 years follow-up, a third of patients progressed from palindromic disease to chronic inflammatory arthritis, with about 90+% of those meeting criteria for RA. And so one, it gives you a number. 2, they also showed, like a lot of the other preclinical RA clinically suspect arthralgia reports that we had from this meeting, that you can stratify patients by risk factors, and there's a score. And the score is based on whether you have what your age is, whether there's rheumatoid factor, whether there's smoking, whether it's CCP, and you get a score. And patients who have more risk factors for developing RA, guess what? Develop RA, and with really high predictive value. And so I liked it because it's about something we don't talk much about. I liked it because, you know, after looking at this and scratching my head a few times, I thought, you know, palindromic RA really is preclinical RA. And we know patients, and we always thought that if they're seropositive, that they're probably going to progress, than not. And so it clears up for me what it was, the enigma of palindromic rheumatism, and maybe it needs to be included. What we really need is a big nosology and classification system for preclinical RA clinically suspect arthralgia, et cetera. Because we're certainly getting closer to developing the risk factors for progression to chronic inflammatory arthritis. All right. Well, I want to thank our discussants for bringing to light some really hot topics in rheumatoid arthritis care. We appreciate your tuning into these panel discussions, and we'll do it again at ACR. David, Orly, John, thank you very much.
Thanks, Jack. Good seeing
Thanks.
everybody.
Thanks everyone.
All right. Have a
Bye.
great
Bye.
night.